We start our proceedings with Dr. Praveen Muraly, vitreoretinal consultant at the Eye Foundation, Kochi. So he'll be speaking on PVD, breaks and lattice degeneration, when to treat and follow up. So we'll all stick to the time and finish it and have a nice lunch.
Start off. Yes.
Sir,
So,
words.
retinal detachment is most challenging. The So retinal detachment is most challenging. Prevention as well as treatment, which is very unpredictable and influenced by a lot of factors. One of the most dreaded complication is loss of vision, hence all this debate and preferred practice. As physician, we are duty bound to search for such visible predisposing lesion in the course of our routine eye examination. There are many of them to be enlisted. They are very common, and it's important to recognize the pattern in it and in order to judge their significance. Can be divided into development, vitreoretinal degeneration, intraretinal degeneration, as well as chorioretinal degeneration. Coming to posterior vitreous detachment, it is basically a separation of the posterior cortical vitreous from the ILM and is the most common cause of floaters. They can be either spontaneous, what we see in old age. Also, it could be seen in any procedures like cataract, refractive, intravitreal injections, etc. They can be complete or partial, the symptoms of which are flashes or floaters. When you see flashes, they are basically the result of vitreous traction on the retina. The floaters may be due to blood from the torn or avulsed retinal vessel. It could be also due to condensation of vitreous or collagen or the glial tissue, as we see is in V's ring. This is quite significant. Any patient with acute PVD with symptoms at the time of initial examination, the percentage of tears seen is quite high. It's almost about 8 to 22%. So whenever a patient comes with an acute PVD, it is our duty to examine the periphery and look for carefully look for any breaks or holes in this patient. The break are defined as full thickness defect in the retina. They can be either asymptomatic or symptomatic. When we see asymptomatic operculated holes or atrophic retinal hole, they rarely lead to RD. So treatment may be considered in certain situations like one-eyed or if patient had a history of other retinal detachment. And literature provide very little guidance when it comes to asymptomatic retinal break. RCTs are not available for this, and there is limited evidence to support for the same. However, when we come to a symptomatic retinal break, they are basically caused due to vitreoretinal traction and associated with flashes and or floaters. At least half of the untreated symptomatic retinal break with persistent traction will lead to a retinal detachment, and the treatment reduces the detachment to less than 5. So this also is quite significant. So whenever you see a symptomatic retinal break, it's better to go ahead and treat the patient. Traumatic dialysis and tear are treated in similar way. Coming to lattice degeneration, it's basically a degenerative process that can predispose to a retinal tear and detachment. It is characterized by thinning, overlying vitreous liquefaction, a firm vitreoretinal adhesion at the margin of the thinning. They can be either along the axis or it could be radial, and radial lattice are associated with much higher risk of detachment. Round holes are frequent within the areas of detachment. So the main intention of all this exercise is to prevent a detachment and improve the quality of life. So our objective should be to identify patient at risk for detachment, examine a symptomatic patient with PVD to detect for any of these lesions and treat whenever required, recognize the evolution of these breaks and lattice degeneration, manage this patient at high risk, as well as educate. When it comes to asymptomatic horseshoe tear, operculated break, dialysis, traumatic retinal break, go ahead and treat the patient. Or when it comes to lattice, atrophic hole, treatment are rarely recommended, and there is no consensus at present for treatment because of insufficient evidence. However, when you see a single-eyed patient, other eye detachment, you can go ahead and treat this patient. Patient at high risk should be educated about the symptoms of PVD, most important, and retinal detachment, as well as value of periodic follow-up examination. Thank you.